understanding of it relates to the challenges. Our understanding is greatly increasing. What's happened over the last 5 to 10 years is we've learned a great deal about different molecular subtypes of endometrial cancer. And the problem has really been that I think in the past we both overtreated some groups of patients and we undertreated other groups of patients. And as we begin to unmask very specific different molecular types based on the genetic mutations, we discovered, as we have with many other tumor types, that it's not really one disease. It's always cancers in the uterus, but it's driven by different mutations and different genes and has different molecular subtypes. And so we now can classify the disease not just by stage, not just by extent of spread, but by the molecular subtype, which will guide us to less aggressive therapy and less therapy in some women, and reserving the more aggressive treatment with surgery, chemotherapy, and radiation for those who have higher risk disease. So that's the direction we're going. We are not completely there yet. We still have a lot to learn and a lot to unmask. And I have no doubt we will identify further molecular subtypes, will further clarify what the most appropriate treatment is for each type. So the challenge is learning all those molecular subtypes, understanding the differences between them, and making sure that we get the right treatment to patients, that those that need immuno-oncologic agents, which is another area of development in uterine cancer, get them, but we don't use them for people who don't need them. So both our increased understanding is actually, in an odd way, also leading to new challenges that we face in using all this information we're gathering. I believe that chiefly it has been the treatment, which I referenced in terms of some of the toxicities. For instance, in endometrial cancer that had actually gone more than had progressed to extending more than halfway through the wall of the uterus, pelvic radiation was traditionally utilized, and in many cases, women would undergo a surgical procedure in addition to removing the uterus, performing a retroperitoneal lymph node dissection. And that surgery was open surgery. It was actually a total abdominal hysterectomy, oophorectomy, and lymph node dissection. Involved opening the abdomen completely. That certainly has morbidities. And pelvic radiation had a lot of gastrointestinal, genitourinary side effects. It's difficult radiation to give. When those procedures are now needed, the surgeries, removing a uterus, even lymph node dissections, can be performed with minimally invasive surgery, with laparoscopy or robotic surgery. And this decreases the side effects and the morbidities of that surgery significantly, and also shortens hospitalizations a lot. Likewise, when pelvic radiation therapy is used, we now have a type of radiation called IMRT, which is intensity modulated radiation therapy. This allows much more detailed treatment fields that don't treat as much of the normal tissue, and significantly decreases the side effects of the radiation therapy. So not that surgery and radiation and even chemotherapy can't impact quality of life, but we've learned to do it with less side effects, less morbidities, and even the chemotherapy now with the use of immuno-oncology agents. There's two that are used in uterine cancer, dostarlimab and pembrolizumab. They're sold under the names Jemperla and Keytruda. Those are better tolerated than many more aggressive traditional chemotherapy regimens. So I think all of the treatments certainly impact the quality of life, but we've learned to ameliorate some of the side effects. The piece I don't want to forget about with all of this is that it can be emotionally trying as well to women to have their uterus removed. And that is certainly can have a quality of life impact. And I don't want to ignore that or minimize that. Yes, there are, and I referenced two of them. We've found that for certain subgroups of patients with endometrial cancer that bear something we call mismatch repair deficiency, also known as microsatellite instability, and these are specific genetic changes within the tumor, they can benefit from the addition of these immuno-oncologic agents, which basically turn on the patient's immune system so it can more effectively fight cancer cells, and this has improved the prognosis. The two agents that are used most commonly, I just referenced dostarlimab and pembrolizumab. So that certainly has been a major treatment change within the world of endometrial cancer. The other ties in a little bit with the molecular subtypes and the identification of inherited syndromes. There's one called Lynch syndrome, and now it's advocated that all women who are diagnosed with endometrial cancer undergo testing for Lynch syndrome, which is a group of genetic abnormalities. The reason this is a significant change in the landscape is if they do indeed have Lynch syndrome. This is an inherited syndrome in the family, and it not only is tied with uterine cancer, but also with ovarian cancer, gastric cancer, small intestinal cancer, pancreatic cancer, brain tumor, skin cancer. So there are multiple, colorectal cancer, which is a big one, multiple cancers associated with Lynch syndrome. And if we identify it in a patient, not that it changes their therapy, but it allows us to test the remainder of the family for Lynch syndrome and steer them towards appropriate screening and earlier diagnosis. And that is the real key to all cancers, is that earlier diagnosis, screening, preventative measures. So that has changed the landscape in terms of our ability to, again, find those patients who we need to follow most closely. And that's a great question. I really like that. And it's an optimistic message that early diagnosis is key. Overall, if one looks at all stages of uterine cancer, the 5-year survival, which is how we as oncologists talk about curing cancers, is 81%. And that's within my world of cancer, that's a very high number. And for disease that's confined to the uterus, early stage, it's 95%, which is, we're talking about the kind of numbers we see with Hodgkin's disease and other very treatable malignancies. And the reason for this is that it tends to present early. 75 to 90% of patients present with abnormal uterine bleeding. And given that the majority of patients are more than 55 years old, this is a huge warning sign. Now, I'm not trying to panic women who have postmenopausal uterine bleeding. In fact, if one looks at all the causes, only 9% of them will actually have endometrial cancer. But that's a huge warning sign that when a woman presents or notices that she is having uterine bleeding, vaginal bleeding after menopause, they need to be seen and they need to be evaluated very quickly, because the early surgery patients with early surgery do very well, and the early stages can often be treated with surgery alone. So that's number one. Be aware of that symptom. It's the way the large majority of patients present, and it can lead to this very high cure rate we see. The other, I also message for physicians is that family history is incredibly important. Identify those patients with Lynch syndrome, because it not only benefits that patient, but those multiple, everyone else in the family who can be screened, and if they had Lynch syndrome, can then be steered to colonoscopies for colorectal cancer, as well as skin checks for skin cancer, mammograms for breast cancer, which is also associated with it. So that's the second message. Look for the family history. You may be able to help a lot of other family members and aggressively work up that uterine bleeding in postmenopausal women.